Hello and good evening, everyone. I'm Dr. Yashika, consultant psychiatrist at Hospital for Mental Health, Vadodara. I would like to express my gratitude to respected chief guests and guests of honor and everyone for being here. Thank you, Dr. Shravan, Dr. Shiv, and the organizers for making me a part of this meet. And thank you, Dr. Manan, for accepting our invitation. Dr. Manan completed his MBBS from MP Shah Medical College, Jamnagar, and MD Psychiatry from AMC MET Narendra Modi Medical College in Ahmedabad in 2020, with gold medal from Gujarat University and moved to UK in 2021. Currently practicing as a consultant psychiatrist in the United Kingdom and is a weekly columnist for Divya Bhaskar and Novat newspaper. He is also a 4-time TED speaker and youngest doctor in the country to give a TEDx talk. He is a member of Royal College of Psychiatrists and one of the youngest consultant psychiatrists in the UK. I welcome you, sir. And the format for today's discussion is an interesting question and answer session. So with your permission, sir, can we begin?
Yeah, please call me Manan.
So for the first question, I would like to ask, as the word stress has become so common, how does a psychiatrist define stress and what are the long-term consequences of chronic stress on mental health?
Right. So to get us started, thank you to the whole organizing committee to start off for having me and for organizing this. I think it's really important that we keep in touch with this side of the things, the brain and neurology and psychiatry, especially people with different specialties. And it's really good that you guys have organized such a wide spectrum program where you've got people from different unions, different parts of the country, and I think we also have some people joining from out of India as well. Personally, it helps me stay in touch with home, which I love doing. So thank you so much for having me. And special thanks to Shravan. Shravan's been a friend since years and years now. So good to get in touch with him again. And thank you to everyone else. So stress, I think, Yashika, it's good that you yourself are a psychiatrist, and it'll be interesting to have this conversation. I think it's really important. We've always studied that there's two types of stress, isn't it? There's eustress and there's distress. And we always keep saying that, I'll always run faster when a dog is chasing me than when I run by myself. And it's that pressure that an exam or a performance pressure that we put on ourselves, which will make us work harder. We'll always study better when we've got an exam coming. And even if we go back to our school days, we'll study harder for the subjects which are counted in the final ranks than for the subjects which aren't counted. So whenever something is attached with a bit of significance, and we can use that as a motivation and do that to sort of improve our performance or improve our effort, then that is eustress. But when it starts hampering our performance, when it starts hampering our mental well-being, our thoughts, our feelings, the way we behave, then it becomes distress. And there's the whole, because it is the World Brain Day and we're discussing the neurology side of things as well, and because we're lucky to have an audience where most of them are MBBS students or doctors themselves, so we can discuss a bit more about the neurobiology side of things as well. And it's the cortisol levels which gets secreted more and more. And if you go into the depth of endocrinology, once your cortisol levels start increasing more and more, in men, the testosterone level goes down. In women, their endocrinological cycle also gets messed up. And then you start having a lot of other problems as well. Distress is just the beginning of where your mental health, and then eventually it starts hampering your physical health as well. So I think it's important to sort of distinguish between what for me is eustress and what for me is distress, trying to identify as to how do I convert this performance pressure into a eustress situation where it's helping me. The sword that I have is helping me perform better and work better, rather than it becoming a hindrance to my own mental well-being.
That's true, sir. Yes. So what are some effective techniques or treatments according to you for managing or handling the distress?
I'd say, at least to start off, some of the very, very basic things, people tend to not focus on physical health. Like, I'll tell you from my own personal experience that before I started focusing on my physical health or working out, that plays a massive, massive role. At the end of the day, we do have to realize that as humans, we are moderated by our endocrinology. And there will be times in our lives when there will be stressful situations, there will be exams, or there will be something going on in your personal life. But at the same time, it's really important to try to make sure that you still do the things that matter to you, like getting proper sleep, making sure that you're eating properly, making sure that you're getting that half an hour, 45 minutes of exercise, mindfulness or meditation. I'm a little ADHD for meditation. So for me, I need to sort of have the motor side of things taken care of in the form of either going on a drive or going on a bike ride or something to that effect, where because a part of your hyperactivity is channelized in something repetitive that you enjoy with say music going on, at the same time you're thinking and you're being honest with yourself. I think all these things, along with the fact that you're brutally honest with yourself about what you think, we tend to displace our anger or displace our stress on someone or something. And if we sit down and mindfully meditate for say 15-20 minutes through the day, just run through the day as to what happened, what you're thinking, what your goals are, what you're working towards, what is troubling you, and then sort of just sit and analyze as to how you're taking it out or how you're channelizing those things, and trying to make sure that we consciously work on being completely honest with ourselves about these things, will help us sort of channelize our emotions and energies in a more constructive way, I believe. So just to summarize, sleep, very, very basic things in all honesty: sleep, diet, exercise, meditation of some sort, of mindfulness of some sort, where you're being brutally honest with yourself, and then having those goals that you set up, which are realistic, rational, and understandable, to sort of help you progress 1% each day.
That is true. So going a little bit deeper in the physiology, are there any specific neurological or physiological markers that have been identified as potential indicators of mental health or psychiatric disorders?
So as you might be knowing, we don't have diagnostic, like as far as us psychiatrists are concerned, the main diagnostic tool that we have is the clinical history. Unfortunately, there's a lot of research going on as far as your cortisol levels are concerned, or if you read about the psychoneuroimmunology, then about interferon alpha and interleukin 6, about them being inflammatory markers, which will then be hampering your mental health and hampering your immunity at the end of the day. But those things aren't right now in clinical practice. Like if you are suspecting COVID, you'll do an LFT and you'll identify whether you've got COVID or not. But you don't have a blood test which your GP or your psychiatrist that you go to in clinics will order to identify whether you've got depression or not. So as far as clinical practice is concerned, we still don't have any blood markers which we will be using to identify whether someone's got depression or whether someone's got schizophrenia or not. But at the same time, there's a lot of research going on as far as the neurobiological basis of it is concerned, and what is being proposed, as you might know, is that it's mainly about the circuits. There was a time in the 1960s, like it's very, very interesting if you look at historically how mental health and the understanding of mental disorders has evolved. It is one of the, I think, the fastest growing sciences as far as medical science is concerned. We know pretty much everything, like not at the cost of sounding cocky, but we know pretty much everything that there is to know about lungs. We know pretty much everything that there is to know about the heart. Fairly pretty much that there is to know about the pancreas. As far as the brain is concerned, there's just so much that needs to be learned and seen. And the main hampering factor, I think, as far as that is concerned, is the challenge of functional neuroimaging. Because at the end of the day, it's so complex and there's so much involved that you will not be able to identify one particular chemical which you can then chase functionally imaging it and seeing as to how the levels modulate. And hence I think the latest understanding is that it's more of the circuits in the brain rather than a particular area in the brain which is responsible for a particular disorder. Like if we're talking about hallucinations, which is a positive symptom of schizophrenia, then it will be your mesocortical and your mesolimbic pathways in the brain, rather than a particular part of your forebrain or your temporal lobe or your frontal lobe, which is responsible and if you press will start causing hallucinations. So it's more based about the circuitry rather than a particular chemical that will be a causative factor or a curative factor. And hence most mental health medications deal with multiple chemicals and not just one. Like your atypical antipsychotics will not only be working on your D2 receptors, they'll also be working on your 5-HT2A and 5-HT2C receptors at the same time. And hence they are working on multiple chemicals at the same time.
Right, sir. So, about the neuroimaging techniques and the advances, do you think that techniques like functional MRI can help us unravel the underlying mechanisms of mental disorders or inform some treatment decisions?
I think it's interesting. It's a good starting point. I think functional neuroimaging is a good starting point as far as understanding mental health issues are concerned. As far as I'm concerned, the most interesting research in mental health happening right now is the whole Neuralink idea that Elon Musk's. I'm sure a lot of people know about Neuralink. I'm not sure, but I'll just throw a little bit of light on it, and then we can discuss more about it if we get more questions. So Neuralink is essentially they cut out a part of your skull, which is 1 millimeter by 1 millimeter in length and breadth, and they replace it by a chip. Now, essentially, if you look at it that way, we're all digital humans. None of us are not digitally connected. All of you are looking at these seminars on your phone or your laptop. And if you look at it that way, it is the most inefficient form of communication between your brain and between the computer's brain. What's the medium of communication? How do you communicate with your digital device? It is through your fingers or through your voice. Right? Now, the processing power of your brain and the processing power of the CPU are both much more efficient than the amount of data that you can transmit through your fingers or through your voice to the device. The only input-output method is either typing or either listening and speaking the commands that you're saying. Like if you search on Google, who's the Prime Minister of the UK, that's just one level of information, whereas your computer is also capable of processing 10 different things at a time, and so is your brain. So that input-output method is the most inefficient method of communication, and that's the problem that Neuralink is trying to solve. So the method of communication with the digital device will then not be your typing or your voice. It will be your thoughts and that being transmitted directly to the digital device, which we've seen in movies and we've seen in things like that happening all the time. But that's the next frontier, and it will most likely be the neurological disorders which will get solved first, and the mysteries of someone having an amputated limb which they're not able to control completely, and through a digital prosthetic device we're able to cure someone who's had a stroke. It will be the vascular dementias which will get cured first, and only after that we'll delve into more complex neurobiological disorders like your schizophrenia or bipolar, which then might get, but it's a stepping stone. Functional neuroimaging is a stepping stone. The Neuralink device is a stepping stone. AI is a stepping stone, and that's how science works, isn't it?
Yes, that's true. So, moving on towards the artificial intelligence part. So, like we have the famous series has come, the Black Mirror. So artificial intelligence is now covering so many aspects of our life. So how is artificial intelligence being utilized in the field of psychiatry and mental health? And are there any AI driven interventions or tools for stress management that have shown promising results?
So to start off, there is this what was that name? I think, let me see if I can find it. There is this AI driven therapy app. I'm not sure if it's still in India or not, but it's called Claire, CLARE. I'm not sure if you search it on Google Play Store, if it'll be available or not in India, but that is an AI driven therapy app. So essentially that app talks to you, it provides you therapy. It is based on the entire concepts of your CBT and DBT, and you'll actually get a telephone call and it'll start talking to you just like Siri or Google Assistant would. That I think is and it's a derivative of ChatGPT. So ChatGPT, essentially think of, essentially the whole world of AI was a unipolar world, and Google was the entire monopoly as far as the whole AI world is concerned. Eric Schmidt, who was the previous boss of Google, the founder of Google, was one of the leading pioneers of AI. And then the whole idea of OpenAI happened. And again, we keep going back to Elon Musk, strangely enough. Elon Musk and Eric Schmidt had this conversation about the fact that AI should be much more democratized. One company should not have monopoly over AI, because otherwise what would happen is if that company falls into the wrong hands, there is complete monopoly as far as your money is concerned, your democracy is concerned, and everything will be in trouble. any monopoly in any business is a problem always. And hence the whole idea of OpenAI started, which was initially supposed to be non-for-profit. It was supposed to be completely science-based company, not a profit-based company. And there was around $60 million, which I think Elon Musk invested in it. And then the company just kept growing and growing and growing. And today we see the version of ChatGPT, which is like where it has cleared solicitor exams, it has cleared medical license exams, it has cleared engineering exams. So think of one conscience, one human being or one brain being capable to clear all these exams. And that is within one server. It is an actual existence. And hence there will be a lot of implications of those AI softwares and those algorithms, one of which, like I said, is the therapy-based app Claire. And there are, again, a lot of other AI tools being developed. One of the researches that I was a part of was about early signs of relapse in schizophrenia. So they would do a telephone call with a person and they would ask some basic questions to that person about how their day has been, where they are, they'll check your basic mental state examination. They'll check your orientation, they'll ask you about your mood, they'll ask you about your thoughts. And based on the lag time that you have in giving those answers, based on the amount of time that you spend between saying words as well, you will identify as to whether your cognition is slowing down or not. And hence it is not just therapy or therapeutic interventions that AI has utility in, but also in diagnostics where things like for dementia, right now the test we use is MMSE, mini mental state, right? Which is like a memory test essentially at the end of the day. But there are ways to clearly identify dementia much, much more earlier through these techniques than a memory test or a structural brain scan like a CT scan. So AI is going to revolutionize not only mental health, but healthcare field in general. We're seeing robotic surgeries and a lot of other things being developed day in and day out. So things are going to change 20 years down the line as far as, not only diagnostics is concerned, but even therapeutics.
Definitely, that's true. So are there any limitations or challenges in integrating AI with traditional psychiatric treatments and practices? And what can be the ethical considerations that can be taken into account?
So I think that the biggest thing is not just for like mental health disorders or psychiatric disorders. It's the doomsday prophecy, isn't it? What if it becomes really powerful? Then what to do?
Yeah.
What if it becomes the end all and be all, because you've got electric cars going everywhere, you've got computers going everywhere, you've got servers going everywhere. What if they just take over? And what if they just completely, we live in a Terminator-based world, essentially, which I know sounds silly, but there are laws being passed and there's practically no legislation or governance as far as AI is concerned, which is scary and which should be scary. There's nothing wrong in that, because you will 5-10 years down the line, the speed at which it is processing. Personal life is a myth. We all know the fact that any one of us who's on Facebook or Instagram or any of the social media platforms, we all know that personal life is a myth. By this time, we know that, if you search anything on Amazon, it will start showing on your Facebook feeds and it will start showing on your Instagram feeds, essentially telling us that, whatever we search across platforms is just a myth. It's all integrated and there's no such thing as privacy. So privacy is a massive, massive challenge. The fact that what if this entire thing takes over humanity, then it's not just mental health. That is a massive, massive challenge. Over-reliance on AI will also, at least for now, take away that human touch, which, especially in a field like psychiatry and mental health, is very, very important, I feel. And hence the complexity of it as well, because one of the main reasons why I took psychiatry is because I felt like it is a very beautiful and personalized field of medical science. It's something which is not only you're calculating, doses and doing that side of things, you're doing that side of things as well. But it's very interesting because every patient is a different story. And there is, like someone rightly said at the beginning of the session, that there is a lot of philosophy and a lot of art attached to it. Psychiatric, I'm sure during your training, your PG teachers told you that, psychiatric history is an art. Yeah. And it actually is, because you are trying to elicit something from the patient, which in a lot of times the patient does not even want to talk to you.
Yeah.
So it is an art to sort of get that history out, try to cater or tailor a care plan which is individualized to the patient. because, and especially when you travel countries, when you move across countries, one of the major things that sort of drove me here was I wanted to see as to how culture and upbringing play a role in, mental health. So it's very interesting across the spectrum, and AI is going to cut across spectrums and, bring you solutions which are across races and genders and disorders. But then it comes with the challenge of sort of probably losing that human touch, which again, AI does poetry as well. So you never know.
Exactly. So we don't know whether it's bridging the gap or making it wider.
Yeah.
So truly a question. So moving on to our next question, how are the advances and any treatment options apart from pharmacotherapy that you can discuss about in psychiatry?
Besides pharmacotherapy, one-on-one CBT therapy, cognitive behavior therapy or psychotherapy is catching up again. Like I think, I'm not sure if Dr. D'Souza is still on the call, but he would recall that 80s and 90s, our senior psychiatrist was, there was an obsession for a couple of decades with biology. And, after the whole Freudian era of Sigmund Freud, by the way, was a neurologist by training. He wasn't a psychiatrist. He was a neurologist by training. And after the whole Freudian era, as far as psychiatry is concerned, there was an obsession with biology saying that, all of Freud's theories are complete BS. There's no truth to it. And, everything is biology, biology, biology. From the beginning of the 2000s, we've sort of discovered that, biology is biology, but psychology is psychology as well. And for every psychological symptom, there is a biological basis to it. And just like you've got exercise, which plays a very important role in management of diabetes, your cognitive dissonances and your cognitive distortions play a massive, massive role as far as your mental health is concerned. And hence, it's not just pharmacotherapeutic treatments which is going to change your mental health. It will be the change in your cognitions and your lifestyle and your mental schemas, which will play a massive, massive role as far as your mental health is concerned. And hence, therapy has as much of a biological basis as does pharmacotherapy. And hence, it is really important to get those therapy sessions in the form of cognitive behavior therapy, or if you've got EUPD, then dialectical behavior therapy, therapeutic groups. There's just so much more potential to, and so much more to mental health treatment than pharmacotherapy. And you see it live, you see it in action, and you see that as far as a lot of disorders are concerned, therapy plays a massive, massive role.
Yeah, that is true. So like in UK, how do you answer the most common question that we usually get here? That how long will it take to show effect? How long will the treatment show its effect? So how do you answer such questions? Are these questions actually even asked there?
Absolutely, absolutely. So, that's what across cultures, one will sort of realize that human beings all over the world are impatient, especially in suffering. Bad times feel much more longer than good times do, but otherwise, by and large, good times are equal to bad times. So whenever you're going through something, you want that suffering to end as soon as possible. And when it takes a lot for anyone to get to a psychiatrist's clinic in any corner of the world. Yes, the stigma in a country like the UK or a country like the USA would be a little less than it would be in India, but then there's still stigma there. And people would hesitate to come to a mental health specialist, talk to them. Again, self-harm, suicide is a stigmatized topic across cultures, across strata. And hence, you do get questions like, how quickly will it take? Do these medications actually work? Will I get dependent on them? Are you just slowing me down? Are you just numbing me down with medications? Will I ever be able to, come off of these medications? It's the same. It's just that the language changes. And hence you answer them the same way that you do in any corner of the world. You tell them that, they will take 6 to 8 weeks, just like you've got diabetes, just like you've got hypertension, and your medications do need to continue for a long or longish time. It's similar with this, and you do the psychoeducation side of things just like you would.
Okay, that's great to know that humans are almost same around the everywhere, like around the globe.
We're all in the same boat. We're all in the same boat.
Yes, that's true. So are there any specific risk factors or vulnerabilities that can predispose someone to experiencing stress-related psychiatric disorders?
Yeah, so as far as the latest research is concerned, and I'm sure a lot of people would have heard the term epigenetics. And epigenetics, essentially, that like there used to be a lot of talk about whether depression is caused by biology, whether it is caused by psychology, or whether it is caused by social factors like, say, someone's parent dying, or someone missing out on a partner, or some major life event. Because then they sort of discovered that, someone else loses their parent but does not undergo clinical depression, but some people do. Some people have psychotic symptoms, but some people don't. So is it just that it runs in families like diabetes does? Or is there a psychological factor associated with it? Or is it upbringing and childhood and what kind of parenting you've got? So it's a combination of all of these three. It's a combination of biopsychosocial, and hence most of the causative models of mental health disorders are based on biopsychosocial model, which is that the biology or your genetics would predispose you, would increase the risk of you developing certain disorders. To say in the least, there would be a preponderance that your postsynaptic neurons would have a little less of serotonin receptors as far as the amount is concerned. That's your biological predisposition to it. Then your psychological exposure or your upbringing and your social stresses would bring that out. If the upbringing that you've got is very scientific, if you've got the right coping mechanisms, if you've been taught from your childhood itself to use mature defenses, and you've got the right kind of stress resilience, then you will be able to have resilience towards stressful events of your life, and you will be able to cope through them despite your biological preponderance to it. And so the accepted model of pathogenesis as far as any mental health disorder is concerned, be it schizophrenia, bipolar, or depression, is biopsychosocial. And just like working out, or just like making sure that you take in the right kind of diet and the right kind of exercise in physical health, important to prevent or manage diabetes, having your right defense mechanisms, practicing mindfulness, managing your stress levels, keeping those endorphins going by exercising is equally important to manage your mental health. And that's where epigenetics comes into play, where, maybe my parents did not live a very healthy lifestyle, but if I live a healthy lifestyle, my genetics would change. And I would then inculcate that lifestyle into my children, who would start, say, exercising from the age of 5, 7, and make that a very important part of their life. So that's where epigenetics comes into play as to how do we change our genetics in not only our generations, but the generations to come as well, and then manage those mental health levels.
Yes, that is true. So, can you speak about the relationship between trauma, stress, sleep, and as we have gone through the COVID era? So, how does this inform our understanding about PTSD or post-traumatic stress disorder?
So, post-traumatic stress disorder was, if you go into the history of PTSD, very, very initially, PTSD used to be known as shell shock. I'm talking about World War II times. It used to be known as shell shock. It was a term which was used only for people for army men who went into war, and when they came back, they used to have this cluster of symptoms where they would constantly have flashbacks of what they've seen, of what they've experienced. They would struggle to sleep. They would struggle to get back into civilian life, and hence doctors used to call it shell shock, and they used to be institutionalized for a little while to help them sort of re-inculcate them into the society, or rehabilitate them into the society. Then, of course, it wasn't a politically nice term to say. So then they started calling it battle fatigue. And this was then hence known as, again, very limited to soldiers and people who've been in wars, etc. And then they sort of discovered that the same cluster of symptoms is also seen in people who, say, suffered assault, been through a massive traumatic incident like a major accident and lost a limb or two, who've undergone, things like rape or murder attempts or robbery. And hence the whole idea of post-traumatic stress disorder or acute stress reaction came into existence. And of course, COVID has sort of left empty chairs on the dining table, and we've lost, practically every family has lost a family member. I'm sure there's probably not anyone in the audience today who's not lost one person that they knew because of COVID. So of course, it's been a stressful event. And PTSD's understanding keeps evolving as far as, but that cluster of symptoms where people get flashbacks, struggle to concentrate or focus on one thing, that starts affecting their day-to-day well-being, is PTSD. As far as the treatment of those side of things is concerned, therapy, again, especially EMDR, which is eye movement desensitization therapy, is one of the most highly evidenced treatments for PTSD. And again, those coping mechanisms that we discussed, that, the more good sleep that you get, the good diet, good social support, good family support, those are, your mental hygiene as far as those things are concerned.
Right. So like in the UK, like here, RTMs and this deeper RTMs are coming into play, and many researches are going on, and many psychiatrists are even getting the machine. So like, how is the RTMS practice in UK?
RTMS is one of the things that I sort of discovered between India and UK is RTMS and DBS, are deep brain stimulation, RTMS, are still fairly equal as far as India and UK is concerned. In the UK, I don't see a lot of ECT being done, which, like when I did my residency from Ahmedabad, and we used to have at least 3 or 4 ECTs every morning as a part of your residency. I'm sure anyone who's done would have. Whereas ECTs are a bit more stigmatized, and you don't see a lot of ECTs happening here. So ECTs, and I think that's what the Mental Health Care Act of 2017 in India also is moving towards. It's making ECTs difficult, but then I know it's a very controversial topic to discuss, and that's a different seminar in itself as to if and when it will be implemented or not. But the Mental Health Care Act of India 2017 is very, very, very similar to the Mental Health Act here in 1983. And hence the importance of the Capacity Act. The Section 89 in India is very similar to Section 2 here in the UK. Section 90 in India is very similar to Section 3 in the UK. I actually did a comparison between the two acts, and it's fairly like it's very, very close and similar. And hence I would have my reservations about the implementation of it as far as our Indian population is concerned as well. And I'm very pro the fact that it needs to change. It needs to change because there's a lot of good things that we're still doing in India, and I don't think those should change. I think ECTs are rightly so the gold standard as far as acute responses are concerned, and they should remain so. We shouldn't stigmatize it too much.
Yeah, there's a lot of stigma around ECT. Patients are so afraid, and like the things that are shown in movies, and there's so much of stigma. Plus, like, whenever they hear the word shock, they themselves get like they're not actually very ready, but it's actually the most safest option, if even more than pharmacotherapy, but it is stigmatized. So, and what about suicides? Like in India, the suicides have become so common in medical students. So what is the scenario there in UK? Like due to increase in stress, and as we were talking earlier about the next and the tougher examinations, it's been so difficult to cope up with everything, the personal life and the professional life. So how are the things in UK?
So it's pretty much, I think, post-COVID suicide numbers all over the globe have sort of risen, because we all had that social cover of friends, family, and those sort of things, which sort of helped us cope through stressful situations. And post-COVID suicide numbers all over the globe have increased, and the UK is very much a part of those increase in numbers. And a lot of different therapies are being tried, and I'm sure you've heard about ketamine therapy being used as a pharmacotherapy. There are new suicide therapeutic tools as far as the psychotherapy side of things is concerned, one of which we're trialing in our organization, which is called CAMS, which is Collaborative Assessment and Management of Suicidality, which was pioneered by someone called Dr. David Jobs in the USA. And it's its third version now. So we used to use DICES as a suicide triage model previously. Now we use CAMS as a suicide triage model, where you talk to a person. It's a very open sort of conversation that you have with the person to identify the stressors and try to put those safeguards in place. Initially, you triage them into 3 levels as to how quickly they need the interventions that you need. Also, I think a lot of new science is moving away from hospital admissions, which I know still is pretty much the gold standard of if someone presents with acute suicidality, you admit them. And it's still pretty much the same here in the UK as well, pretty much the same in any corner of the world, because they do need a timeout. In some cases, people do need a timeout, and people need to be in a situation where, there's a change of scenario from their home, they need their things to be taken care of. But then institutionalizing someone, putting them in an acute mental health ward, might be counterproductive as well. So there's a lot of work being done as far as whether do they need to be in an acute mental health ward against their will, or what's the right treatment setup, or what's the right treatment placing. And that is probably one of the interesting conversations to have as to managing suicidality is concerned. But as far as increasing rates of suicidality are concerned, I'm pretty sure that it's increasing everywhere.
Yeah. We are also seeing like a hike in number of cases, especially in amongst medical students. And in spite of being aware in everything, the cases are on a rise. So we actually need to do something about some therapy, or like the ketamine is working great. Well, but still the rates and the ratios are still on rise. So and like the last question I would want to ask you about like cannabis and other stimulants, like what is the use of all the stimulants there? Do you think it would actually be therapeutic or counterproductive, and patients would actually misuse it? Like, it's been legalized in so many countries. So what is your say on that?
Right. So this was one of my MD exam questions, actually. My 20-mark question was legalization of cannabis. And I've got a very clear view on it. I know where I stand as far as cannabis and legalization of substances is concerned. So as far as psychedelic-based therapies is concerned, it's a very interesting part of mental health, where using LSD to achieve that trance and then giving that therapeutic intervention is concerned. This is something that has been in research for at least the past 200 years. And then in the 1950s, 60s era, which was considered to be the hippie era, as far as the world is concerned, where, the world moved towards westernization and people started using drugs recreationally much more than what they used to previously. The whole idea took a pause for a couple of decades, but now it's catching up again. So psychedelic-based therapies are things that, as a psych student or a psych resident, you would have seen loads and loads of conferences happen on it, and they still do. There's still a lot of research going on. There's still a lot of conferences happening on it, and there's still a lot of trial centers where they do psychedelic-based therapy. Of course, it's not licensed and it's not in common use, and hence we can't recommend it to anyone because a lot of research is still going on. However, there's a very, very big difference between legalizing something and it having therapeutic value. Alcohol is legal, but that doesn't mean it's good for you. Junk food is legal, but it doesn't mean it's good for you. Cigarette smoking is legal, but it doesn't mean it's good for you. So a lot of people feel that just because cannabis is being legalized, it's good for me. And hence it is going to be better. And that's where one needs to have that rational thought and rational mind as to, I'm very against restrictions, but I'm very pro common sense. And that's where people sort of struggle. So the thing is, in Australia, in Netherlands, in a lot of states in the USA, these things have been legal for ages and ages. And one thing that, you shouldn't compare it to, but I'll give you a very controversial example: prostitution. Prostitution is legal in Netherlands. It is legal in Australia. And you are seeing sex crime related crime statistics go down in those countries since then. Similarly, whenever recreational use of drugs has been legalized, you are seeing crime rates go down. Why? Because all these, when it is not legalized, it's not like your consumption rates are going down. Your consumption, Gujarat is a dry state. We all know what the reality of that is. And hence you're seeing that there is no legal consumption, but there'll still be illegal consumption. And that illegal consumption will be by unfair means. That money will be black money, which is being circulated. And hence the legalization of cannabis is not a healthcare issue. It's a social issue. It's the kind of money that is being poured into and out of the system. The fact that the government want to extract taxes from the use of cannabis and make roads and buildings and make their own money with it. That's the question. The question always never is whether it's good for your health. Cannabis is not good for you. You as a psych resident would have seen umpteen number of cases, I'm sure, during your residency, where after a couple of exposures of cannabis, people present with acute psychosis. So to all the medical students who are justifying or rationalizing it to themselves by saying that, oh, it is legal in this country, so it must be good for me. No, it's not good for you. Alcohol is legal. Smoking is legal. It's not good for you. It's just that they're legalizing it because you're going to consume it either ways.
Yeah.
And hence they want to make money out of it. And they want you to pay taxes for it. That doesn't mean it's good for you. It's bad for you.
Yes, that's true. That's an interesting take on that. So thank you so much. It was such an interesting session and such a deep conversation. And I really thoroughly enjoyed it and looking forward to more such conversations. So at the end, sir, would you like to address our medical students and say something like a message for them?
No, just thank you so much for having me. It's been an absolute pleasure. And like I said, I love keeping in touch with India, staying in India, and this gives me an opportunity to do so. It was a fascinating conversation and we could keep going on and on, I'm sure. But thank you so much to the whole organizing committee, everyone, Yashika, Shravan. I'm just reading out all the names that I can see: Dr. Abul Hassan, Dr. Shiv, Dr. Jyoti, Dr. Lakhan, Meenu, Dr. Shivani, Dr. Prachi, and Dr. Raghunandan. Thank you all so much for having me. It's been an absolute pleasure, and I look forward to seeing all of you soon.
Thank you. Thank you so much. It was our pleasure. So moving on forward, I would like to hand over to Dr. Shivani Trivedi, co-founder of Web Colloquium, past national coordinator of SNO India, state leader of IMA MSN. And over to you, Shivani. Thank you so much.
Thank you so much, Dr. Yashika. An honor to have you, sir. So, greetings to everyone, including our amazing speaker, Dr. Manan Thakrar, sir, our chief guest, Professor Dr. Russell D'Souza, sir, and guest of honor, Dr. Abul Hassan, sir, Dr. Shalabh Gupta, sir, and Professor Dr. Mary Matthew, ma'am. I extend my sincere thanks to them for taking time from the busy schedule to be with us here today. Thank you so much, sir. Thank you so much, ma'am. It's an honor to have the opportunity to express my appreciation to all the dignitaries present today. A special thank goes to Dr. Shravan, sir, and Dr. Shiv Joshi, sir, organizing chairpersons of this webinar, and for their unconditional support in making this a success. My heartfelt gratitude also goes to our organizing coordinators, Dr. Jyoti R., Dr. Akshay Yadav, Dr. Lakhan Gupta, Dr. Indranil Deshmukh, and our organizing conveners, Dr. Meet Konia, Dr. Venkatesh Karthikeyan, and Dr. Kavya Shah. A big thanks to our organizing moderators, Dr. Yashika Nathani and Dr. Kena Gandhi. Our organizing secretary, Dr. Raghunandan R., and our host, Dr. Garima Garg and Dr. Rajneesh Raj. Special thanks to the Clarnet team, Ms. Latika, Ms. Prachi, Ms. Soma, Ms. Ankita, and Ms. Jyoti. Thank you so much for sharing with us the platform to have this wonderful session. It's my honor to be a part of this great team. Their hard work and spirit in organizing this webinar has been outstanding. I'm grateful to the esteemed delegates of this webinar for their presence and efforts in making this event a success. To all our participants, thank you so much for joining us today in this webinar. Hope you had a wonderful time and a wonderful session. Thank you.
Thank you so much for extending us the opportunity to host the session, especially the organizing chairperson, Dr. Shravan Dev sir and Dr. Shiv Joshi sir. I hope you had a seamless experience. So with all due permissions, I'm closing the session today and looking forward to hosting you again.
Thank you. Thank you.
Thank you. Thank you so much. Good night. Take care. Thank you.
Good night.
Good night. Good night.
Good night. Good night.